So we are going to get started with our webinar. I think we will expect a few more participants to join us. Greetings to all the participants. On behalf of Tufts University, I would like to welcome you all to our webinar. I'm Rahel Gizau, Senior Learning Advisor on the Growth Through Nutrition project. The impetus of today's webinar is, as you all are well aware, the novel coronavirus is imposing unprecedented health, nutrition, social, and economic risks to the global population. Ethiopia is also being affected, and if the virus continues to spread, it will have the potential to reverse some of the nutritional gains that the country has achieved in the past few years. This calls for joint efforts by key stakeholders to help support the Ethiopian government's strong commitment to preparedness and response to combat the epidemic. In light of this, Tufts University, in collaboration with Save the Children, has organized this webinar that will bring together representatives from government, civil society, and academia to discuss lessons learned, practical and innovative approaches regarding COVID-19, different sectors' adaptation and response plans, and recommendations to address the current and future epidemic and minimize its negative impact on nutrition. We expect the webinar to last for an hour and a half, and it will be delivered using PowerPoint presentations followed by a 30-minute question and answer session. Our speakers are Professor Eileen Kennedy, a professor at Tufts University, Friedman School of Nutrition Science and Policy, Dr. Sisai Sinamo, Senior Program Manager of Quota Declaration Federal Program Delivery Unit, and Dr. Amara Daribo, Country Director for Nutrition International Ethiopia. Professor Eileen starts out by giving us an overview on COVID, which will be followed by two presentations from Dr. Sisai and Dr. Amara. They will share with us their perspective on lesson learned, practical approaches, and recommendations representing government and civil society, respectively. I will introduce each of our speakers before starting each presentation. I'll be moderating the session, and I have colleagues working in the back who will be collecting questions and also provide technical support to ensure we have a smooth and productive webinar. I would like to share a few ground rules to make the webinar productive. Participants, please turn off your camera for better connection, and speakers, please mute your microphone unless it's time for you to speak. Participants, please forward your questions during the webinar by using the chat box at the bottom of your screen. It would be good if you could also include the name of the speaker you'd like to respond to your question. During the question and answer session, speakers will try to address the questions from the participants. The webinar is being recorded and will be sharing audio recordings and presentation as well as learning documents and news item on the webinar to all the participants in the coming few days. We will also post some of this material on our Growth Through Nutrition project website. Now I'd like to introduce our first presenter, Professor Eileen Kennedy. Professor Eileen Kennedy is a former Dean of Tufts University, Friedman School of Nutrition Science and Policy. Currently a professor at the school, Professor Kennedy's research interests include assessing the health, nutrition, diet, and food security impacts of policies and programs, and nutrition and agriculture linkages. Professor Kennedy is a member of the high-level panel of experts on food security and nutrition of the UN Committee on World Food Security, and she's also a member of World Economic Forum Global Council on Food Security and Nutrition. Professor Kennedy founded and was the first executive director of USDA Center for Nutrition Policy and Promotion. Professor Kennedy created the Health Eating Index, which is used as a single summary measure of diet quality. We're very glad to have her today on our webinar, so I would give a chance for Professor Eileen to start her presentation. Thank you.
Thank you, Rahel. And let me send my greetings to participants who are joining us from around the globe. If I could have my slides, please. I would like to provide an overview on COVID-19 food security and nutrition. And in the next slide, we see from WHO some data that are as of September 13th, 2020, so very recent. And if we could look at within each region, the first column talks about new cases of COVID in the last 7 days, listed in percentages. And what we see there, the Americas, 38% of the new cases have come from the Americas, followed by 37% in Southeast Asia and 16% from Europe. If we, on the same slide, go to the third column, which talks about cumulative cases in percentages, the contribution of the Americas in percentage is even greater. 51% of the cumulative cases of COVID come from the Americas, followed by 19% Southeast Asia and 17% in Europe. And let's go to the last column, which talks about cumulative deaths. And what we see there is, I think, an alarming statistic. 55% of the cumulative deaths have been contributed by countries in the Americas, followed by the third line down, 25% from Europe, and then Southeast Asia, 10%. The very last line on this slide looks at the same statistics globally. And in the last column, where we look at 100% of the deaths, which when this report came out was a little over 917,000 deaths. I just found out yesterday that the number of worldwide deaths has exceeded 1 million. And the vast majority of those deaths are coming from 4 countries: the United States, Mexico, Brazil, and India. And in the next slide, we see this graphically, where you see the very dark orange, red, and the orange colors indicating parts of the world which have contributed the most and are most at risk. In the next slide, I define food security. Food security exists when all people at all times have physical, social, and economic access to sufficient, safe, and nutritious food, which meets their dietary needs and food preferences for an active and healthy life. Food insecurity is the flip side of this, or as the slide says, food insecurity is the absence of these conditions. Next slide, please. There are several pillars that relate to food security, and I would like to look at, we should have some action on this slide, availability, access, utilization, and stability. And in the next slide here, availability relates to the supply side of food. And this can be determined at the food production level, stocks that are available, and net trade. And when we talk about food security and availability, it's availability at the national as well as the subnational level. And of course, what's availability at the household level. Access, we've already talked about in our definition of food security, which is physical, social, and economic access. And it's determined primarily by incomes, expenditures, markets, and prices. We'll look at that more in a little detail. And finally, utilization. It's not simply the availability of food, household having access, but also utilization, which is a function of good care and feeding practices, food preparation, diversity in the diet, intra-household distribution, and this ultimately is one of the key factors determining the nutritional status of individuals. Next slide, please. So at a very aggregate global level, let's begin to talk about the effects of COVID-19 on food security and nutrition. I pulled out this headline from a New York Times article which appeared in April 2020. Instead of coronavirus, hunger will kill us, emphasizing that the coronavirus is exacerbating an already severe hunger and food insecurity situation. The World Food Program in this second bullet indicates that the number of people experiencing hunger is projected to double from about 135 million prior to the pandemic to approximately 200 160 million. And maybe not surprisingly in this third bullet, the majority of people affected by COVID-19 will be in low and middle income countries. And again, here we have a quote from the World Food Program economist. These people did not need COVID-19, even without it, without COVID, their lives were hanging by a thread. So let's go to the next slide. The causes of increased food insecurity, and I know the speakers that will come after me will talk about this in a little bit more detail, but the aggregate causes of food insecurity, increased food insecurity, are first, at the country level, lockdowns contributing to dramatic increases of in unemployment and decreased livelihoods. If people can't go to their jobs, unemployment obviously increases and livelihoods are affected. Now, along with, concomitant with the unemployment and decreased livelihoods, we see a decrease in income. And we'll look at that in a bit at both income at the national level as well as household level. We know from data that poor households are more likely to lose their jobs, have decreased income, and lose their livelihoods. We also know that poor households are more likely to buy food which are inexpensive or cheap, but low nutrient density. And finally, diets will be heavily based on processed foods, basic staples, low levels of animal source foods, low levels of fruits, low levels of vegetables, and a worst case scenario, food intake will decrease dramatically. Next slide, please. So here we have a chart, a table from a recent report by International Food Policy Research Institute, which looks at percentage change from base year. Let's look at that first column, real gross domestic product, which is a measure of country or national income. We see at a global level, at the world level, real GDP or real income at a country level has decreased by 5%. Go down to the fourth line, and what we see there is what's the effect in countries in sub-Saharan Africa. And there, the effect on national income is even more dramatic, hitting a decrease of almost 9%. If we go to the next column where we look at what is the effect of this on household consumption, and of course this includes food consumption, again at a global level we see household consumption decreasing by 1%. But again, let's go down to the fourth line and look at sub-Saharan African countries, and what we see there is income has, consumption rather has increased even more, over 3%. If we could have the next slide, please. Now, this is just one example, again, from the IFPRI report and other sources which are listed at the bottom of this table. And I pull this out because this is a specific example of Addis Ababa in Ethiopia. And the reason I am emphasizing in this particular table dairy consumption is we know that animal source products are a key part of a nutritionally adequate diet. And we know very specifically it's critical for dietary diversity and nutritional status of preschool age children. And the two bars in this represent two different time periods. In the green bar represents what happened before COVID, which was January 2020, January, February, and then the yellow bar represents what's happened in May 2020. And so let's look at the first two green and yellow bars average. In January, February, we had, again, in Ethiopia, in Addis, we had about 55% of households consuming any dairy. This dropped precipitously to about 45% after COVID in May 2020. You go to the next two sets of bar charts, the poorest quintile, the poorest 20% of the population. Again, not surprisingly, before COVID-19, their consumption of dairy products was already low at about 30%, but it dropped dramatically to 20% after COVID. And if we look at a further disaggregation by poorer households, middle income, rich, and richest quintile, the group of households least affected, meaning the group of households where dairy consumption decreased the least before COVID to after COVID, not surprisingly, are the richest 20% of households. And as you go down to the poorest quintile, these are the households most effective. And going back to the New York Times article, these households were already hanging by a thread. Hunger and food insecurity was already a problem in these poorest households, and it has gotten worse. Next slide, please. Now, what we see here is that we did say unemployment has increased, incomes have decreased precipitously, but there are some job categories which are more affected than others. And let me emphasize here the first three. Primary production is the category of jobs most affected negatively. And this, of course, involves farm level production, jobs at farm level, particularly small farmers, food processing. The whole value chain within our food systems has been affected. And food services is the third category to be effective. Obviously, with lockdowns, people can't get out to markets, can't get out to restaurants, can't get out to wet markets. So this has been a massive negative effect on these first three job categories in the value chain. Next slide, please. Now, that was food security. Let's look a little bit at, from an overview, what has happened to nutrition. Again, here, the World Health Organization is predicting dramatic increases in malnutrition in both the short and longer term. And I hope in the question and answer period, we can have some discussion of longer term implications, because so much of what we've been looking at globally has been a short-term perspective. But both in the short and longer term, the World Health Organization predicts poor diets and a strained and overburdened health system. And going back to the slide, which talked about what is happening to national incomes, national GDP, where incomes at country level are decreasing, this affects the ability of governments to sustain health systems to respond to the increased need due to COVID-19. We also know from a large body of research that poor nutrition contributes to a weakened immune system and can leave people vulnerable, particularly those with underlying respiratory illnesses. What's becoming a little bit clearer, again, these are all new data because COVID only emerged in the early parts of 2020, but what is becoming clearer is that obesity is a very critical underlying condition that contributes to increased mortality. And if I could look at the next slide, again, very new data. This comes out of a Journal of American Medical Association, New York City. 5,700 COVID-19 patients, 12 hospitals in New York City. These are underlying conditions, and I think the authors of this report were maybe a bit surprised that the second most common underlying morbidity or adverse condition, topping over 40%, is obesity. And if we can look at my final slide, again, a very recent study. This slide looks at people dying from COVID, the odds of dying by age and by obesity. In this case, obesity defined as a body mass index greater than 30. So let's look at the overall. The overall odds of dying, so that's overall, and then compare it to those younger than 65. Obviously, younger people, the odds of dying, less likely to die. Look at what happens when you have a combination of older people, in this study, 65 years and older, combined with obesity. A twofold, almost a twofold increase in odds of dying when you're older and obese. And if you go to the upper age groups, and let's hone in here on those 75 to 84, almost a threefold increase on the odds of dying in compared to those who are less than 65. We will be seeing more and more of these data because I know a lot of studies are going on, not simply out of the United States, but out of other countries. And alarms go up in thinking about it's not simply COVID, but how do we deal with the underlying conditions from a health, nutrition, and safety net perspective. And I think some of my other presenters will be discussing this a little bit more. Thank you. I appreciate having been given the time. Thank you, Rahel.
Okay. Thank you, Eileen, for your clear and great presentations. Participants, please forward your question using the chat box. Now I will introduce our next presenter, Dr. Sisai Sinamo. Dr. Sisai Sinamo has a doctorate degree in medicine, a master's and a PhD in public health nutrition. Dr. Sinamo has over 18 years of international experience in the field of developmental and emergency health and nutrition, and experience in managing multi-country programs. In his prior position as nutrition advisor for World Vision International, he coordinated 26 African country nutrition programs and provided technical support in many areas, including nutrition governance. In July 2017, Dr. Sinamo joined the Quota Declaration Federal Program Delivery Unit at Federal Ministry of Health, Ethiopia. As a senior program manager, he is responsible for providing technical and administrative leadership for the federal and regional program delivery units. So I'm going to give a chance for Dr. Sisai to start his presentation.
Thank you so much, Rahel, for the kind introduction. I will be talking on the impact of COVID on nutrition, specifically focusing on the Ethiopian context. Next slide, please. So this is the talking points. I will be starting with the potential impact of COVID on nutrition, followed by what lessons we learned, and also the roles of the various sectors in COVID preparedness and response, and also what kind of adaptations as a country we made for better response to the epidemic, and also the practical and also innovative approach that were used to mitigate and respond to the COVID that could be also adopted to other countries' context. And finally, I will make a few recommendations. Next, please. To put the attendees in the context, I want to speak maybe this slide only on the Quota Declaration. As Rael said, the Quota Declaration is an innovative government of Ethiopia's commitment to end stunting among children under 2 by the year 2030. And this declaration has a 15 years roadmap, which is divided into 3 phases, which we call it the innovation phase, the expansion phase, and also the scale-up phases. Currently, 9 sector ministries are working together: health, agriculture, water, irrigation, energy, education, labor and social affairs, women and children affairs, transport, finance, and culture and tourism. And their counterparts at regional and Warada level also work together for the innovation phase of the Quota Declaration. During this phase, we are testing 6 innovations. Now, the one that I'm leading is the Federal Program Delivery Unit, and also we have 2 program delivery units at regional as the 2 regions. This is testing the governance for nutrition. The second is a community lab. A community lab is a community-driven process where the communities identify their own problem related to nutrition and solve using their local available approach. And the third one is the first 1,000 days plus public movement, where we do social and also behavioral change communication using the 1,000 days approach. And the fourth one is agricultural innovation and technologies to improve food and nutrition access using agricultural and water innovations. And the fifth one is a Coastal Warada-based multi-sectoral nutrition investment plan, where all the sectors that I mentioned earlier, they work together to develop a costed plan which could be financed by Waradas, regions, and also the federal government. And finally is a data revolution, which is generating an evidence base for the work that we do, using also assessing the performance using a scorecard for the respective sectors. And as I said earlier, the 15 years is divided into 3 phases. Currently, we are now concluding the innovation phase and also making preparation for the expansion phase, which will extend between 2021 and 2025. And based on this learning, now the national scale-up will be started in 2016. So this is just to give you the context of the Quota Declaration and also how we have been responding to the COVID-19 to address the issue of stunting, and also other challenges in the health and other sectors. Next slide, please. So among those sectors, I will be focusing specifically on the two essential sectors that are working on nutrition, the health sector and also the agriculture sector. So what were the potential impacts that we have anticipated and worked on to address the impact on the health and also agricultural sector? On the health sector side, especially to avoid the delivery of essential health and nutrition services, one of the potential impacts that we anticipated was a disruption on essential health nutrition services that is being provided by frontline health workers at the health post, at the health center level, as well as also in the hospital level. The second potential impact that was anticipated was shortage of essential commodities at all levels, including drugs, therapeutic products, as well as also other essential commodities needed for prevention as well as also rehabilitation of nutrition. The third one is a shortage of IPC and PPE in the health facilities due to commodity constraints. Of course, the health, staff usually use the personal protective equipment, but when there is a high caseload and also frequent utilization of these commodities, we expect a shortage could happen. The fourth impact that was anticipated was the low quality of essential and emergency services, including referral linkage. This is particularly due to some people may not come to the health facility or may come late, and also many health workers may not get the essential equipments and commodities to provide these services. And also inability to conduct a face-to-face health workers training as well as community-based SBCC activities. As we all know, nutrition services, most of them are provided either through counseling, individual counseling, group counseling, or home visits. So because of that is also another impact. And also, of course, the other component is a high cost of transportation or cancellation contributing delayed in the timely arrival of essential commodities. I think, as Professor mentioned, one of the impact was on the price side, and we also felt that there is also the potential impact on the transportation. One, because of the rise in the transportation cost, or even in the human transportation side, because of the restrictions made to mobilize people. There was also another impact that we have observed. On the agriculture sector, especially in terms of availing essential food commodities in the market, the first thing that we observed was the staples and nutrient-dense food price has been increasing. So that was the anticipated impact. And also these other studies also clearly indicated that compared to other seasonal costs, there was an increase in the price for various food commodities. And compared to other findings, there was a huge reduction in the animal source food consumption, vegetable fruit consumption due to misconsumption. I think this one, of course, the cost has another component, but when it comes to animal source food consumption, vegetable, people were afraid to consume, especially those products that were available afresh. So there was this impact was also observed. And another anticipation was the increased market price for spices. I think like garlic, ginger, citrus fruit, chilies, and honeys, people felt that this could also contribute to build the immunity, and there was also even lack in the market of some of these products. There was also an increased spending on transportation. One is due to reduced number of passengers per vehicle. This will also affect the availability of food. And finally, there was also an anticipation in terms of increasing price for agrochemical fertilizers, animal feed, and others due to one, market shortage of availability, and also the second is in terms of the transportation of these commodities. So having this in mind, potential impact, the government and also the sectors started working on the response plan. Next slide, please. So what did we learn from this approach in terms of our response? The first thing is in terms of responding for nutrition, sector is nutrition is really a very sensitive sector in terms of when we face such kind of global pandemic like COVID-19, because as a country, we have already carrying a huge burden of people under the safety net program. Currently, we have over 6.8 million people under the rural safety net program, nearly 100,000 people under the urban safety net program, and also in terms of moderate and severe malnutrition among under 5 children and pregnant and lactating women, we have already over 3 million people. In terms of some cases, close to 450,000 people are already currently in the program. So when we face such kind of shock, it is really sensitive in terms of aggravating the situation. So what we learned was, to manage and respond appropriately, it really requires an appropriate leadership, providing directives and guidelines, and also close follow-up to ensure the service continuity, because already we have a huge caseload that could easily be affected. So in this regard, the government has put in place from the federal government level up to the Warada, which is a district level, a very clear governing structure and also accountability mechanisms. As a ministry, both Ministry of Health, Agriculture, and other sectors have already developed directives and guidelines that are contextually relevant guidelines to ensure that the service needs to be continued so that we shouldn't have any more morbidities and also mortalities as a result of COVID impact. That is number one that we learned. So the second is in terms of tools, logistics, and commodities are really critically needed for frontline workers to provide and sustain services. As I've already said, we have already a huge burden of malnutrition, as well as also a large number of people already in the safety net program. So we have to provide appropriate tools, commodities, as well as logistics that needs to be needed to sustain the program and also prevent any effect that COVID could bring about. The third is information tracking and sharing. What we did was, in terms of information tracking, for instance, for some cases, we used the existing platforms like the EPHI, the weekly emergency tracking system was activated to track a weekly admission and weekly mortality, especially for some cases, and also work using the productive safety net in terms of how many people could be potentially affected if this situation worsens or continues. So that information has been reviewed on weekly basis, and also timely corrective actions have been made. And also we used also a multimedia platforms to activate, were activated to provide the right and timely information, especially our excellencies, the ministers, the state ministers, the experts have been on media to provide the right message in terms of what to do, what not to do, so that people really understand the COVID situation, and also to create demand for services, because at one point people were afraid even to come to the health facilities to take services. So in terms of ensuring and also creating demand, a lot of multimedia communication has been done. And finally, nutrition cannot stand alone, because nutrition is really requires, even for the Quota Declaration, we are using 9 sectors, but as a national program, we are using also 19 sectors. So all the sectors really have to do their part and also work together to make sure that the population is not affected. Next slide, please. So in terms of the role of the sectors in COVID-19 preparedness and response, I think, as I said earlier, though the impact could vary from sector to sector, as also Professor has mentioned, there is no sector that could be exempted so that they shouldn't prepare preparedness and response plan. So all sectors are really need to work to respond for the COVID-19, and that is what happened in our case. And also the response, as I said earlier, was led by the highest government authorities at federal, regional, and local level, so that they could also mobilize all the sectors and act their role. In case of the Quota Declaration, all the 9 sectors were also affected, so each of them have developed their preparedness and response plan that is tailored to the respective sectors and also understanding the complementarity among the sectors. Of course, there were a lot of global guidances and recommendations have been provided by WHO, UNICEF, FAO, SAN, and also other global platforms. They have been instrumental in making key decisions at local level. We are still using the recommendations and guidances until now. So those guidances has been tailored and also locally adapted to make it relevant for our context. Next. So in terms of adaptation to respond to the COVID-19 situation, the first thing is contextualized global recommendation to the country situation. I think this is the most relevant, even other countries really need to learn. In Ethiopian context, we have the global recommendations, but when it comes to our country context, we have made contextualization to make it at country relevant. For instance, in terms of the lockdown, we have not made those decisions to lock down the cities or like the workstations and the other things. But what we preferred was to minimize for instance, in the case of our case, to minimize the number of staff that will come to the office, and also to reduce the number of people that use the public transport. Of course, the school has been closed, public gatherings has been restricted, but still the country has been functioning, but repurposing, the various roles, the various sectors have. So, for instance, this season we have a huge rain, and also it was an agricultural season. We can't stop importing fertilizers, seed, and other commodities, because if we really miss, this season opportunity, the next season we will be facing a huge malnutrition and hunger and food gap in the country. So the government, through Ministry of Agriculture, has made decisions that, during, even if it is a COVID context, we have to make sure that all farmers need to be on the job, continue working on the farm so that they can produce adequate food for the next season. But in those cases, they have to also use the COVID preventive measure. So contextualizing the global recommendation is something that we need to make a very good adaptation in the response of COVID situation. The second thing is major adjustment, making adjustment for the staff work schedule and also frequency of information exchange between federal, regional to facilitate early detection and action for any potential impact. Information needs to be shared among the federal, regional sectors and also the various departments, so that each of the required sectors need to make an appropriate decision. I'm not sure where I am in terms of time, but let me know if I'm beyond time, right?
And now it's okay, you can continue.
Okay, good. We also conducted, for instance, in the case of the Quota Declaration, once we adopted the global recommendation, we also did a rapid assessment to see what is the effect of COVID-19 in terms of the implementation of the ongoing program. Because in the Quota Declaration case, we have 9 sectors. There is already a federal government budget allocation, regional government federal allocation. Many activities are going on. So we need to assess the impact and make adjustments. So that has really helped to make it also locally relevant actions so that the service will continue, both agricultural services, the health services and other services also could continue through the sectors. We also reprogram planned activities because we can't go business as usual. So it has to be tailored to COVID-19 response and impact mitigation plan. All the sectors have also made reprogram their activities. And also, like any part of the world, I think this is the same. We also transitioned a lot of face-to-face events, review meetings, high-level forums into virtual, as well as also reduced, for instance, in the case of health sector, one of the guidance provided was to reduce the frequency of clients' visit for nutritional services. If they are coming weekly, they have to come every other week. If they are coming every other week, they have to come every month. Such kind of guidances has been made. Next. Next slide, please. So what are the practices and also innovations? I can't say innovations, but the critical practices that need to be adopted into other contexts. I think the first thing is, as I said earlier, adopting the global recommendations to fit the local context is really relevant, because one recommendation that may work in other country, it may not work in another country. So global recommendations could be made, unless it is related to services. If it is a very general recommendation, that has to be looked at, how does that fit into the country context? So such kind of dialogue has to be made at country level before making it like a textbook kind of recommendations and making it into on the ground. The second thing is to conduct rapid assessment on the impact and taking locally relevant measures. At the country level, at federal level, at regional level, at Warada level, there has been a lot of dialogue and also rigorous follow-up of the COVID-19 situation by high-level authorities, technical people, and also local leaders. So those kind of assessments has really helped Ethiopia to manage the impact. We are still managing the impact, but that has really been really relevant. And also the third one is multi-stakeholder and multi-level platform led by the highest government authorities, really needed because many decisions need to be made very fast. In this case, leadership from that is being given at the highest level will really help to make decisions quickly, as well as also make adjustments easily. The fourth is accountability is really needed. If there is no one is accountable for the decisions and also for the actions being made, the response will be very difficult. So accountability for functionality of services and also for monitoring the impact, conducting the surveillance, both market surveillance, a lot of actions has been done, even financial injection for the banks to really sustain their workers, and also monitoring the market price and all other things has to be made, and also all the relevant people needs to be accountable, and also use of available financial technology and human resources to support the response and impact mitigation. In Ethiopian case, we used like universities to produce antiseptics, the industry parks to produce masks, and also resources has been mobilized locally to address the most vulnerable people, and many other things really has been made. So I think it is good also to use what is available locally to make it relevant to address the impact, as well as also make appropriate response. Next. So this is the final slide in terms of what kind of recommendations can we really make. The first one is building capacity of community-based nutrition services, providing facilities with personnel and equipment to provide services without interruption. I think in Ethiopian case, the establishment of the huge health extension program across the country, the large number of health centers, health posts, the frontline agricultural extension workers, the wash service providers, the women networks, all of them, has been key, really instrumental to quickly sustain the services. Because at one point the service have, especially when we get the first case of COVID-19, many people were reluctant to go to health facilities to access and also access nutrition services and others, but the reactivation of those platforms had really helped to regain the services without interruption. The second thing is pre-positioning essential nutrition commodities, infection prevention equipment to prevent pipeline breaks. One of the things that we were also working with UNICEF was, for instance, for nutrition, in case of nutrition, is to pre-position the nutritional therapeutic commodities so that in case the COVID-19 lockdown continues globally, we might have a very shortage of the therapeutic products. like the drugs as well as also other equipment. So we have been working to pre-position commodities for longer period of time. For instance, in case of agriculture ministry, they have been pre-positioning seeds, fertilizers, and other commodities so that there should not be a pipeline break. And also, like the government has been really following up the essential food commodities availability in the country so that the markets could be regulated. And also new way of delivering services, especially like in Addis, like the oil price, the wheat price, as well as the bread price has been really stabilized because the government has been pre-positioning and also opening new innovating approach to really stabilize the market. The third recommendation is diversified approaches are needed to create demand and avoid missed opportunities and reduce clients' frequent visit. You know, when the health facilities visit was declining in early March, what we have done was there has been a lot of diversified approach of communication to create the demand. The media like TV, radio, as well as also mobilization of the frontline workers to really to create demand and bring back the service so that the impact should not affect already children already in the program as well as also newly malnourished children. And also for the other sectors, it has been also been done the same. So there needs always to be a diversified approach that needs to be put in place to create demand and also avoid missed opportunities. For instance, people who have been in TB treatment, HIV treatment, and also other treatment, antenatal care follow-up, they shouldn't have those missed opportunities. So a lot of sensitization has been done. The fourth one is to develop strategies that could absorb shock and to provide access to staple and nutrient-dense foods. So this is something that we are still working on as a country, but there needs to be a strategy that really needs to absorb shock, especially in country where staple and nutrient-dense foods are scarce for the most vulnerable population. And finally, to develop and sustain multi-channel systems to generate information, track progress, communicate information, and make timely decision-making. Of course, information was coming from various sectors through their own channel, but those channels need to be sustained. You know, we have developed a lot of systems to generate information for COVID-19, but how can we really sustain those systems so that we can use them in the long term? Those things are need to be considered. For other also, this is something that other countries can also learn. So this is what I want to say. Thank you so much. Back to you, Rahi. Thank you.
Thank you so much, Dr. Sisay, for your great presentation, for your great and thorough presentation. You have highlighted a number of key lessons and recommendations that includes the importance of all sectors working together to support government's preparedness and response plan, as well as the importance of contextualizing global recommendations for Ethiopian context. Now we will be moving forward to our next presenter, Dr. Amara. Participants, please continue forwarding your questions on the chat box. Okay, so Dr. Amara is a country director at Nutrition International in Ethiopia. As a country director, Dr. Deribo oversees advocacy, planning, and program development and implementation. He is a public health specialist and epidemiologist with more than 14 years of experience in leadership, program management, research. Prior to joining Nutrition International, Dr. Deribo was program director at International Medical Corps in Sudan and Sierra Leone. He worked as an epidemiologist with Oxford University and with KEMRI Wellcome Trust Research Program in Kenya. Dr. Deribo has a medical degree and a master's in public health and a PhD in medical science. Dr. Deribo has published several academic articles on reputable journals. So Dr. Amara, please, you can continue. You can start with your presentation.
Thank you, Rahel, for the introduction and for inviting me to this important webinar. So I will be presenting on the potential impact of COVID on nutrition and best practices and the roles and responsibility of stakeholders in Ethiopia. And I would also put some recommendations. Next slide. So my presentation outline, first I will be discussing the global impact of COVID and the impact of COVID in Ethiopia. And then I will discuss what are really the actions needed during the COVID pandemic, what are really the best practices and potential adaptable ideas, and roles and responsibilities of stakeholders and the way forward. Next, please. So as you know, the COVID pandemic has actually a very grave impact on the socio-economic status of the world. Maybe this is one of the worst time after the Second World War. So COVID has a huge impact on the economy and disruption of the food system and the interruption of the health services. So the recent published paper in the Lancet showed that the gross national income per capita may be reduced by 8% because of loss of job and remittance, because of disruption of the food system. So more than 140 population may be thrown into poverty, and the decline in GNI would really increase the prevalence of wasting by 14%. Which has also impact on mortality. So an additional 6.7 million children will have severe or moderate wasting because of COVID, and this would result in more than 128,000 deaths. So 20% of these deaths would be in Africa. So UNICEF has also estimated that in the early phase of the epidemic, the essential health service coverage will be reduced by 30%. So that would also have impact on wasting and mortality. So COVID has actually impact on all forms of malnutrition. I'm just presenting its impact on wasting, but it could have impact on all forms of malnutrition. I'm sure other papers may be published in the Lancet soon on impact of COVID on maternal nutrition, dietary diversity, and micronutrient deficiencies. Recently, there are no really papers on the impact of COVID on other forms of malnutrition. As I said, COVID has also impact on health service provision. So, for instance, if you see the service provision related to malnutrition, 51% of countries has some form of service disruption, 46% partial disruption, and 6% had really very severe disruption of nutrition services. Next, please. So what is the impact of COVID in Ethiopia? So COVID has actually impact on remittance. Remittance is one of the economic source for Ethiopia. So remittance may be dropped by 10 to 50%. Job loss, as professor said, 2 to 3 million people might lose their job, and 2 million people may fall into poverty, and GDP is expected also is expected to fall by 5 to 16%, and price inflation is also one of the impact of COVID, which we have already felt it, and it is expected that severe acute malnutrition would be increasing by 10 to 15%. So the emergency nutrition information system also showed that if you see this graph, the bold red line, the admission of severe acute malnutrition from May to July is very high as compared to last year, the same months. So this could be really, one of the reasons could be COVID. We may not, of course, link, we may not say cause-effect relationship, but I think COVID could be one of the reasons because it affects food security. We will see actually the impact of COVID on food security. Of course, one of the other reasons could be the revision of the guideline itself. But I think we can't, rule out the impact of COVID on this, on the increment in admission trends. So if you see in Southern Asian nationalities region, the admission rate is increased by 22%, in Benishangul 21%, and in Amhara by 27%. Next slide. So the impact of COVID on food security was also assessed by IFPRI in July. So 2/3 of the respondents indicated that their income would have were lower as than expected in May. Less, poor households were actually affected by food insecurity. For instance, if you see the second bar, almost 75% of the yellow bar, 25% of poor households were not able to eat healthy and nutritious food because of COVID, as compared to 50% of the rich households. The last bars actually showed the severe form of food insecurity. 17% of poor households indicated that they were hungry, but they didn't eat because of lack of money and resources. So this indicates that COVID has impact on food security, and the poorest households were really very much affected than the richest households. So what nutrition actions are really needed to, to mitigate the impact of COVID? So I think several actions should be needed at individual, community, and national and global level. Next. So at the individual level, individuals should really get well-balanced diet and meal, particularly diet, vitamins and minerals are really very essential. So we should really advocate and we should have strong SSA/BCC and systems to avail healthy diets. The other issue is individuals should also, practice healthy lifestyle. We have to do exercise. We have been noticing in Ethiopia that people are doing exercise at home. They should avoid harmful practices like smoking and alcohol and drugs. At the community level, there should be systems to ensure availability and access and affordability of essential food commodities. And we should avoid, panic buy, and the government and communities should really work together to ensure better access to food communities. At the national level, there should be systems and policies to ensure availability of food commodities, essential health services, and taxation of subsidies for healthy and protective diets. At the global level, the world should work actually to avoid trade restrictions to ensure access to nutrition commodities. Next slide. I think the best practices for Ethiopia, since I have already discussed them, maybe I can touch some of them. So as you know, in the early phase of the epidemic, the government has taken very useful measures emergency task force and were established, and emergency resource mobilization team was set up, and the government has expanded actually treatment center, and testing capacity has increased very significantly. National guidelines were developed and distributed and shared to all stakeholders, including the nutrition response plan, which has actually helped a lot to coordinate all stakeholders. And Ethiopia particularly has also the health extension program on the ground, which actually helped the country to mainstream COVID-related messaging. And particularly in the early phase of the epidemic, there was also strong engagement of stakeholders. And the Prime Minister himself, he also initiated a meal sharing initiative, particularly in Addis Ababa. Many thousands of poor people have been benefited from the meal sharing and the food ration distribution. I think these are some of the best practices that Ethiopia can share to other countries. Of course, there are areas also that should be improved. For instance, there has been a shortage of personal protective equipment in some settings, particularly in some of the health facilities. And despite the government commitment and strong advocacy, we don't see really, people are practicing the preventive aspect of COVID. For instance, in many settings, social physical distancing is not respected. People are not wearing face masks properly. In some settings, they don't really wear face masks. That actually raised a question that we could really have a better SSC-BCC strategy by involving in media and other stakeholders. Particularly, just like the HIV era, we should involve really the families affected by COVID in the BCI initiative, in the Behavioral Change Intervention Initiative. So that is, I think, one of the areas that should be improved. Coordination platform is still, it is weaker. So particularly in the regions and in the woredas, I think that has to be also be supported. I think government has also a very big flagship program, like the Quota Declaration, as is CSI presented, and the social safety net programs. So these flagship programs also should mainstream COVID in the future. Next slide, Rahel. So the other country which has also one of the best practices, Senegal, and just like Ethiopia, Senegal has also set up national response plan considering 3 scenarios: best, mid and worst scenarios in the beginning of the epidemic. They have also engaged stakeholders ahead of time, donors and civil society organizations. And they have also set up, a mechanism to distribute food kits, which is made up of, rice, oil, sugar, and hygiene kits. That is, I think, one of the best practice of Senegal that should be also adopted by other countries. They also used digital technology to, disseminate message to the community and other stakeholders. And they have also developed maternal, newborn, child, and adolescent resilient plan. And they have also introduced an incentive to improve service utilization. They give, hygiene kits for population who utilize health services. These were actually some of the practices in Senegal. But there are also areas that needs to be also strengthened in Senegal, like better management of public gatherings, more support for public, poor households, and mechanisms to sustain the incentive mechanisms for the beneficiaries. Next slide. Next slide. The other country is Kenya. Kenya has also, you know, the COVID, the burden of COVID was very high, but recently Kenya has already controlled the burden of COVID. And I think the response to of Kenya is also almost similar to Ethiopia and Senegal. One of the initiative that should be, I think, adopted by other countries were also, you know, they have involved the young group in using the social media to raise awareness to the population. I think that is also one of the areas that should be adopted by Ethiopia and other countries. Next slide. There are also some practices on access to food for children. You know, schools were closed, but some countries has designed mechanisms to ensure access to food for children. For instance, Costa Rica, they had school canteens, and later on they had collection points for food for children. India, they have involved teachers to distribute food to localities. UK, they have designed mechanisms to support families to access food items. For instance, supermarket vouchers and canteens for children of families working in the police. And Brazil, they have also, you know, used cash. You know, they injected cash through family cards. That cards were used actually to get school materials, so they use that card to transfer money to the poor household. Potential adaptations, I think that's where actually advocated by UNICEF and many other NGOs are actually use of, you know, the digital technology such as web-based survey, e-health platform, and so on. And in wasting of management, you know, family work and community-based approach were also, you know, advocated. I think some of the countries are adopting those NGOs, and some countries are adopting those mechanisms. I think we will see how effective are these potential adaptations. Next slide. The role of stakeholders in Ethiopia, as you know, there are so many civil society organizations in Ethiopia. Almost all of nutrition partners have actually adapted their programming in Ethiopia to support the government. They have, you know, mainstreamed COVID in their nutrition programming. For instance, community mobilization. Many of the NGOs have been supporting the government to mobilize the community to raise awareness, and they have supported health facilities and communities to practice, you know, to ensure infection prevention and control systems. They have also supported the government to provide personal protective equipment to the frontline health workers. And most of them were also engaged in health system strengthening by deploying more people to train and support the extension workers and health workers in the primary health care unit. So I think there are so many innovative ideas that were actually tried to support the government to mitigate the impact of COVID in Ethiopia. So for instance, Nutrition International, we have also responded to COVID. We have developed in the early phase of the epidemic, we have developed a nutrition response plan. The nutrition response plan, we're focusing on actually health system strengthening. As part of that, we deployed zonal coordinators to support the government, you know, to coach staff and, you know, disseminate PCI message. We have also supported the health facilities, particularly the primary health care unit, to improve quality of service. You know, one of the big initiative of the government is the government has already committed to sustain basic health services. So we need to support actually the basic services to improve quality of data and so on. In the early phase, there was some decline in service utilization, but because of government commitment and support from civil society, so basic services are really maintained. Particularly recently, the service provision is as usual. So we have been supporting the quality of the service using the so-called collaborative quality improvement approach, which is one of the government priority. So we have also designed a COVID-sensitive BCI strategy, and we are also supporting the regional health bureau by giving grant directly to the region, so that they would also mainstream COVID in the nutrition programming. Next slide. So this is the last slide. So the way forward or the recommendation, one of the recommendations, we need to improve coordination and accountability, particularly in the regions and in the wards and in the zones. So civil society organization has to support the government to improve coordination and accountability. For instance, the civil society coalition SAN, which is led by Save the Children, we are now launching regional platform to support coordination and improve accountability. The other recommendation is we have to improve quality of the integrated nutrition programming. So particularly during the COVID pandemic, we need to really support health extension workers and the primary health care units to improve quality of data and service through, tailored SCBCT and so on. We have to also improve data quality and utilization. As I said before, one of the advocacy agenda for UNICEF and the global technical group is actually to use the existing data for action. So we need to first strengthen the utilization of data using the available system. And it is also good to adopt, introduce mobile and web-based system if the impact of COVID continues. So simplified approach on waste management, as I said, family work, community approach, and so on. We have to have also a coordinated approach to ensure an uninterrupted supply chain. As Dr. Sisay was saying, fortunately, thanks to the government and partners, including UNICEF and NI, nutrition supplies has not been a problem in the last couple of months. So I think such kind of planning and initiative should continue. The other is we need to really do a lot of advocacy and communication to ensure access and utilization of healthy diet. So, poor families particularly does not have access to protective diet. One is misperception, the other is actually price inflation. So there are a lot of brokers and middlemen who could actually, who are the cause of, one of the cause of price inflation. So we need to really make an advocacy, and market system should be really seen again, and government has to have mechanism to ensure access to market to those protective diets, and government has to be committed to really subsidy healthy diet for the poor. And the last recommendation is we need to have also strong, government should have a really strong resource mobilization strategy to achieve the SDG target, because some of the gains has been already reversed by COVID, so more resources needed really to achieve the SDG target globally, in general, particularly in Ethiopia. Over to you, Rahel. Thank you very much.
Okay. Thank you, Dr. Amara Deribe, for your presentation. And now we are finished with all the presentation. We will be quickly moving forward with our question and answer session. So far, we have received around 5 questions. So I'll be reading the questions. by indicating the name of the speaker should be addressing the question. The first question goes to Dr. Eileen. It is from Lu'ul Berhanu from Grocery Nutrition Project. He says most of the evidence and lessons on the effect of COVID-19 on food security and nutrition are so far from semi-urban settings and overnutrition affected communities. Are there any global lessons and recommendations from the more self-productive agrarian or rural communities? This question is to Dr. Eileen. And there is also a second question to Dr. Eileen. Is there any specific global approach or progressive agenda happening concurrently at the moment to help developing nations such as Ethiopia mitigate or reduce the impact of COVID-19 on food and nutrition security, and thereby decrease the incidence or prevalence of acute malnutrition at different levels? And also to save gains achieved so far from different programmatic investment.
Thank you. Do you want me to proceed, Rahel?
Yeah, let me ask the next question and
okay.
we can go to
Good.
the next round. Okay, Dr. Sisai, did the rapid assessment you mentioned in your presentation indicate an increase in the case load of malnutrition and the nutrition health services most affected? This is from Abdulhalik, research manager at Tufts University. And there's also one, any of the panelists could respond. The main sources of food for consumption is from local production, and from your presentation, you are associating the food and nutrition insecurities with COVID-19. Have you seen the other contributing events happening in Ethiopia, like flooding, internal displacement, and security issues? From your own review and experience, how much are these factors attributing to nutrition and food security? This is from Germay, EPHI. Yeah, so any one of you can address this final question. If we have more time, we'll take another round of questions. Thank you. Eileen.
Yeah, thank you. So let me discuss the issue of peri-urban areas. For example, clearly the data I presented on dairy consumption was from Addis Ababa. And given this is such a new phenomenon, COVID-19, what we're finding is data are emerging, but they're clearly not as extensive as they will be 6 months, a year from now. So I'd hazard a guess, given what we've seen from Dr. Sisay and Dr. Amari's presentations, that we can't make any statements about all countries or all areas of the country. For example, Dr. Sisay and Dr. Amari's presentation show quite a bit of variability in issues like prevalence of severe acute malnutrition, stunting in different parts of Ethiopia. Now, I haven't seen a lot of data from Ethiopia about effects across the different regions and sub-regions in the country, but I would make a prediction that a lot of the effects, negative, and a lot of the response to those effects will be heavily driven by the infrastructure that's available in different areas of the country. So for example, infrastructure related to roads, distribution system, transportation. And what we know is in getting a product from one area of the country to another, if you don't have a transportation system that's intact, that has been disrupted, is going to have an effect. We see this, I don't want to use the example of the United States, but I will, huge amounts of accumulation of certain products, not that the product wasn't there, but couldn't be distributed to other parts of the country. And so that inevitably is going to be an effect of availability of commodities both within the country, but also, and I did not mention this, closure of borders. Ethiopia was one of the countries later on in the system to close borders. This has an effect, obviously, in trade across countries, trade of labor across countries. So very complex scenario. And I'd have to say there is not a one-size-fits-all answer to what the effects are when one gets beyond the urban or peri-urban area. Depends on infrastructure, hard infrastructure, and human capital infrastructure. I also had a question about different times during the year. The data I presented, again, they are not data collected from Growth to Nutrition, but we're comparing January, February to May. Now, if we had looked at, for example, parts of the year where there's fasting, again, those average data would be very different. And I think this emphasizes, with whatever indicator we're looking at, it's so much driven by context specificity. And yes, thank you for bringing this up. We can't have a boilerplate answer, or what I mean, we can't say one size fits all. This is going to vary enormously within a country and also across countries. Thank you.
Thank you, Eileen. Dr. Sisai, do you want to address the other question?
Thank you so much, Rahel. I think some of the questions are obvious. For instance, like the flooding, the displacement, the security. These are the short-term effects that easily predispose families' food and nutrition insecurity. So on top of COVID, Ethiopia has faced all these challenges during the last 6-7 months. So as we know, the number of vulnerable population has already increased, which means that more people are on food and nutrition insecurity as a result of flooding, as a result of internal displacement and insecurity. I think to manage that, the Emergency Preparedness and Response Commission that is dedicated for this one, they are handling that jointly with other sectors. So I think this is an obvious cause that will really have a direct effect on food and nutrition security. The second one is the rapid assessment. I can say two things. One is, as Dr. Amara also presented, during the initial phase, like early March and also early April, there was a sharp decline in terms of the admission rate on the therapeutic program, especially the OTPs admission. This is because of people were afraid to come to the health facilities. Screening was not done actively, and also the referral linkage has not been functioning well. But if you see the graph, as of late April, the number of admission has gradually increasing. So up to the last, the 25th epidemiologic week, we have been tracking that, and there is a gradual increase in terms of admission cases across the country. So what does that mean? Now, a lot of studies has to be done. Is this different compared to the previous season of similar year? Because we expect that during the rainy season and early September, October, this is the hunger gap season where the number of malnourished cases will rise. So does that different from the previous season? Was it because of COVID? That needs really further study. The second thing is in terms of the COVID mortality. Globally, it is expected that the COVID could have a huge effect on mortality, either directly through the infection process on malnourished children because of immunity compromisation, as well as also the effect on food and nutrition insecurity. But when we see the mortality trend across the last 6-7 months, it's almost stable. That does not mean that COVID does not has effect or the mortality has not changed. So I think it's good, to have further study on this aspect also. Why the mortality trend is stable? Is it because of the therapeutic intervention, or didn't affect really young children seriously? All those things really needs further study. Many studies indicated that the COVID effect on kids is not compared to adults and so on. So I think those requires really study and clarification to provide a clear answer in terms of the effect. But overall, in Ethiopia, the caseload in terms of admission has been increasing the last few epidemiologic weeks, but the mortality across the months has been stable. Thank you so much.
Okay. Thank you, Dr. Sisai. We have additional 4 questions. Sorry, we are a little over our time, but we'll take the next 5 minutes. We'll try to wrap it up in the next 5 minutes or so. So the next question is for Dr. Sisai. What changes are made to address nutrition community issues given the pandemic? Were there any strategic changes? This question is from Zanabu, a health and nutrition advisor at Save the Children on the Crossroad Nutrition Project. And there's also a question for Dr. Sisay, or Dr. Amara could address this. As we enter into the new Ethiopian fiscal year 2013 in July 20, how much do you think has anticipated COVID response affected or informed government of Ethiopia planning of 2013? What are the costed nutrition plans in case of Quota Declaration initiative or CSO's planned activities? Do you think adaptations for the year still keep nutrition a priority agenda at different levels? This question comes from Lu'ul Berhanu, Deputy Chief of Party at the Crossroad Nutrition. We have any of the panelists can also respond to this question. During stay at home, families are with their children for the whole day. Does this has any positive impact for children nutrition? This is from WASH advisor Asjallo Sidalil from Crossroad Nutrition Project. And the last question is for Dr. Amara, who were targeted by the COVID sensitive BCI strategies and other supports you did at the PHCU level, and how did it help in increasing the demand? This is from Abdulhalik, Research Manager at Tufts University. Thank you.
Thank you so much, Rahel. Maybe let me address a few of the questions. The first one is on the commodity. We used two approaches. The first one is because now I'm referring a timeline like March, April. At that time, the decision that the government has made was, one, to preposition a 6-month commodities for all health facilities. We have worked with UNICEF, ENA, and other stakeholders to make sure that all health facilities have adequate therapeutic, especially now I'm referring to therapeutic foods, for minimum of 6 months. That is the first thing that was done. Distribution has been done, all transportation has been done to the respective regions and health facilities for a 6 months forecasted commodities. But one other thing that we estimated was there could be excess case load as a result of COVID. So for that, a resource mobilization strategy was developed, resource was secured, and also procurement is now in pipeline. So we have now at least a 1-year commodity for the COVID response, considering also the excess case load. Of course, UNICEF has also some shortage of resources that is still being mobilized. The second thing is in terms of the planning, the 2013 government plan all has considered the COVID response as well as also COVID as an impact. Because COVID has made a lot of impacts on the way we operate, both nutrition service provision as well as also resource allocation. So for instance, for the Quota Declaration, like the government has made last year, over $16 million has been allocated for the Quota Declaration. This year also, over 460 million birr has been directly committed by the government for the Quota Declaration. So still the government prioritized nutrition, even in the context of COVID and also with a huge resource constraints. The same in the Warada Costed Plan. Warada Costed Plan refers a multi-sectoral plan that is being made by all sectors. So all sectors, when they do their planning, they have also considered COVID as part of their plan. Maybe let me give Dr. Amara for the other questions. Thank you.
Thank you very much, Rahel. So to respond to some of the questions, I think COVID is not the only cause of food insecurity, as Dr. Sisay was saying, but the study which was done in Addis by IFPRI, it indicates that COVID might have impact on food insecurity, but flood insecurity and other causes are already there. I think more study can be done to see actually the impact of all those factors on food insecurity. The planning that the government include COVID in the planning, I think Dr. Sisai has already mentioned. For instance, if we see the PNSP5, which will be launched in next year, so I have seen that COVID is well reflected and included for COVID. The BCI related to the question related to the behavioral change interventions of NI. We have we have focused actually both the community, the beneficiaries, and the health workers. We are sure that it may have impact, but it is recently introduced. We will be actually evaluating the impact of the BCI strategy and the tools on demand creation and service utilization. That has to be evaluated. It is very early to say that it has an impact. There is one question, one interesting question. Families are staying at home. Does it have positive impact on nutritional status of children? I think that is one of the areas that should be studied, but you know, when families are together at home, they are exercising, you know, different kind of cooking, different kind of, you know, food recipes and so on. It may have positive impact, but I think it should be one of the study area that should be evaluated. I don't have any study actually evaluating that one. Over to you, Rahel.
Rahel, can I add to Dr. Amari? I totally agree with what he just said about children being at home. There could be a lot of positives, particularly for young children, getting more attention from parents and other adults in the household. I know an issue that has come up, though, in many, many countries is where children were receiving some of their meals at school and schools have been closed. That could be a negative. And I was impressed. I think it was Dr. Amari who talked about one of the approaches is distribution of food kits. So I think where we see positives, in this case on children, let's enhance those positives. But where we see negatives, let's look at some of these innovative strategies like food kits to offset some of the negative consequences. And I know we're going to end, but let me just, my final comment is we've spent a lot of time in this webinar talking about some of the shorter term effects. We need to be clear that there may be longer term effects of this pandemic. And from my point of view, one of the aspects of this webinar that has been invaluable is looking at strategies that have been used, sharing this information. And if indeed we will have a rebound, which is being predicted by WHO and groups like Centers for Disease Control, if the COVID is rebounding later this year, I think we have the opportunity to build on the wealth of information that has been presented here and elsewhere on how to contain a COVID if there's a rebound and what are some successful mitigation strategies. So thank you for all of the rich discussions and the presentations, but also in the questions that have come forward. Thank you. I think you're muted, Rahel.
Thank you, Eileen. I would like to thank all of our speakers for their great presentations and for adequately addressing the questions from the participants. I would also like to thank all the participants for active engagement and participation. And last but not least, my colleagues for their support to ensure we have a productive webinar. We hope you have found the webinar valuable, and we look forward to your participation on our next learning event or webinar, which will be coming up soon. As I mentioned earlier, video recording, PowerPoint presentation, learning materials, and news item on the webinar will be shared with all the invited participants, and we will also be posting it on our project website. Thank you so much for your time and participation.
Thank you.
Thank you.
Thank you.